Matthew Steliga, thoracic surgery here at UAMS, and we're going to go through a simulation of chest tube placement. Okay, the first things we do with chest tube placement is we verify the patient's identity, we confirm the imaging studies, get a consent form, and do a timeout. That's standard for any kind of procedure. After we've done those things, we get our supplies ready. And supplies would be sterile gloves, gown, hat, mask, and a chest tube insertion kit, chest tube box right here, and a chest tube itself. Smaller bore chest tubes are used for pneumothorax, and larger bore chest tubes are used for hemothorax or empyema or infection. The smaller tubes would be like 24 French or so for air, and the larger ones are 32 to 36 for fluids. So we'll get started. Patient positioning. The patient is typically lying supine on a bed. For the model here, the head would be this direction, feet are down here, and this is the left side. So we're going to simulate a left chest tube placement. We would get the supplies ready with our chest tube box is filled with water, and the tubing is positioned where it can be easily connected to the chest tube. Normally you put a mask on with gown, hat, etc. I'm not going to have a mask for the purposes of this so I can speak a little more clearly, but we put on a hat, and we would take a sterile gown and have a sterile gown placed. Normally you have an assistant who would fasten it behind you. Once we've done all that, we get our supplies set up. The chest tube insertion kit contains just about everything you need except for the tube itself and the collection box. This is opened in a sterile fashion, and I typically like to have it on a little bedside tray table next to where I'm working. It helps to have an assistant, but sometimes you can just do it on your own and you don't always have an assistant. So we open this in a sterile manner. You can see on the inside it has just about everything we need, all laid out in a good order that we would actually use it. We confirm their identity. Timeout. This is Mr. Bob Smith, left side of pneumothorax, and our plan is for a left chest tube. And then we confirm that with other people in the room. Standard prep is done with, in this kit, it's with a chlorhexidine swab, starting centrally where we would place the tube and making sure to prep the entire skin surface area. The intended area of placement is the mid-axillary line on the side of the patient, approximately fourth interspace. The axilla has the pectoralis muscle in front, latissimus muscle in the back. We're going in between those muscles. Right in the bed of that is the serratus anterior muscle. After we prep, we allow it to dry, and a drape is placed. If the patient is awake, you can talk to the patient and inform them of what's going on each step of the way. Just put the plastic paper drape on you, keeping everything nice and clean. We get some of our supplies and equipment out and ready. These things can just be discarded. Typically for this type of procedure, we would use both IV medication, such as morphine, and local anesthetic, like lidocaine. You can calculate the dose of lidocaine needed for each patient. It's around 4 to 5 milligrams per kilogram of body weight. For a 70 kilogram patient, that's around 30 cc's. Take the time to figure out what your dose of lidocaine should be. There's no reason to skimp on that. This is not a comfortable procedure, and we want to give them as much local as we can. So for this patient, we'll pretend he's 70 kilograms, comes out to just a little over 30 cc's of lidocaine. If the kit does not come with the amount that you need, you can get that pulled for you. And again, don't skimp on the lidocaine. This is not a comfortable procedure, and you want to help the patient with as much local as you can. Well, ampule is cracked, opened, and we use a filter needle to first draw it up. And then after it's drawn up, we get rid of our filter needle, and then we use our injection needle, 22 gauge. The area of the chest, approximately 4th intercostal space, will be palpated. Pectoralis muscles in front, latissimus muscles in back. Right below the axle is our serratus anterior muscle. We feel, even with the nipple line, for the rib spaces. That area of the skin is injected, and you can discuss this with the patient. Mr. Smith, you're going to feel a little needle poke and some burning. Let me know how you're doing. And you can take it slowly. Once the skin is anesthetized, go a little deeper. Go through soft tissues. And you can feel the needle bumping on the periosteum, numb up around the rib. We all know that the nerve, artery, and vein live right underneath each rib, and so we want to avoid injecting directly into a vessel. If you are below the rib, aspirate first before injecting. So once we get that rib and the intercostal spaces fully anesthetized, and let's just say that we've given our full 30 cc's, the whole area is anesthetized, and as we're infiltrating, it's important to aspirate back. You can tell if you're in the pleural space, because if you aspirate back and get air, you know that you've gone too deep and you're in the pleural space, and come a little more superficially to numb things up. Once your local has been infiltrated, give it a few minutes to start working. And our next step would be an 11-blade scalpel. All right, Mr. Smith, you're going to feel a little pushing. If you feel anything sharp, you let me know. Try to brace my hands so I don't move when the patient might be wiggling a little bit, and incise the skin like that. Once the skin is incised, we get our hemostat ready. Next, we get our chest tube ready and waiting for us. We use smaller chest tubes, 20, 24, 28 for pneumothorax. Larger chest tubes, 32, 36 would be for fluid or blood. And it comes with a tapered end. This won't connect to the drainage reservoir very well at all. So this needs to be cut. I typically cut it at just a little bit of a bevel, and that facilitates connection to their chest tube box. Okay, now we have our chest tube ready and available. I clamp the tip of it with this to help guide it. And then we're gonna, with our tube and everything ready, we're going to make our tract. We've made our skin incision. Okay, Mr. Smith, you're gonna feel some pushing. If you feel anything too sharp, you let me know and we'll give you some more numbing medication or some more IV pain medication. So at this point, the tract is dilated and you can feel with the finger. Your goal is to go over the top of the rib. And once your clamp is rubbing right on the top of the rib, the pleura is right beneath it. Oftentimes that can be the most painful part. The clamp is inserted and inserted into the chest just a centimeter or so. You don't want to go very deep. If these are the ribs, and you're going in, you don't do that. Don't jam the clamp in several centimeters. You could hurt internal organs, cause bleeding, all kinds of problems. You just need to insert just enough into the chest cavity to breach the pleura and then spread, okay? Another place where people run into trouble is, we know that the intercostal nerve, artery, vein live on the underside of each rib. If you go over the top of the rib, but take it at a funny angle, you can harm the intercostal bundle on the rib just above you. So it's important to enter on the top surface of the rib and stay perpendicular, okay? All right, so once we've gone in, we've dilated our tract, we feel it, we feel where our rib is, that pleural space is entered. You'll often get a rush of air or fluid, and when that happens, you withdraw the clamp slowly, and you can feel with your finger that there's an adequate tract to insert the tube. At this point, our tube is taken, and through the tract, it's placed on the top surface of the rib, and it's slowly advanced. And then when it's just in the pleural surface, it needs to be advanced. These markings, 2, 4, 6, 8, this is how many centimeters from the last eye hole in the tube. So once it's in the pleural space, it's advanced, and the rubber skin's kind of gripping that there. Okay, there we go. And you want to get it at least a minimum of 6, 8 centimeters in. If you just suture it at the 2 centimeter mark, when the patient stands up, this will pull out. So you want to go a few centimeters into the pleural space, and you want to make sure it's not kinking or folding. And this can be done by making sure that it twists or spins easily without being kinked. Once it's in the pleural space, if you can direct it a little more anteriorly for a pneumothorax, a little more posteriorly for hemothorax or effusion. Once it's in the pleural space, if we need to collect a specimen, this wouldn't be for a pneumothorax or hemothorax, but say there's a effusion that may be a malignant effusion or an infectious etiology, we would get some fluid into this cup and sterilely collect it for either cytology or microbiology. Once that's done, we get our suture. An O-silk suture on a cutting needle is what comes in this kit, and that's a good strength to hold it in place. Okay. There we go. And let me grab the scissors. It's important to suture these chest tubes in well. A flimsy knot can just pull right out, and nobody wants that. So you place an adequate bite of stitch through the skin around the chest tube. It's drawn up. The needle is cut off and placed in a sharp container. And a couple throws will hold this close to the skin. You don't want a big gap between your tube and your knot where it'll wiggle and roll around. You want to keep it pretty snug so it has less mobility and less chance to work its way out. Now, we've tied our chest tube down, and once it's secured in place, we want to make sure that that knot's nice and solid. Okay. Don't want that coming out. Cut the tails. Then someone would hand you the tubing from the drainage reservoir, and it'll have a sterile cap on it. You uncap that, connect it firmly, and hook it up to the drainage box. At this point, we remove the drape and re-examine and evaluate our patient, and we order a chest x-ray. Chest x-ray will confirm placement of the tube and look for good re-expansion of the lung with drainage of the fluid or evacuation of pneumothorax. That's about it for a standard bedside chest tube placement. Thank you.